Hello, and welcome to Health is the Key, the podcast that explores the health and wellness issues that matter to 1199 SEIU healthcare workers. I'm your host, Elizabeth Moore. May is High Blood Pressure Education Month, and so today we're focusing on this all-too-common condition, also known as hypertension, that affects nearly half of all adults in the United States. We'll also look at the new guidelines issued for cholesterol, because high cholesterol combined with high blood pressure significantly raises the risk of heart disease, stroke, and other serious conditions. To help break it all down, we're joined by Dr. Mary Gover, a general internist at Montefiore Einstein Advanced Care. Dr. Gover will walk us through the basics of hypertension, explain the role cholesterol plays, and share steps we can take to keep both under control. Welcome to Health is the Key, Dr. Gover.
Thank you so much for having me. I'm excited to be here today.
Thank you. So I guess we should just get started with the basics of hypertension. What is it? How is it measured? And what do the numbers mean?
I think we all know from going to the doctor, when you get your blood pressure checked, there are two numbers that are written on the paper. The top number is the pressure in your blood vessels when your heart is pumping blood through your body. And the bottom number is the pressure in your blood vessels when your heart is relaxing after it's pumped. So we're kind of getting a look at how much pressure is being distributed through your blood vessels when your heart is both pumping and relaxing. And so that's those numbers. The top number would be the systolic blood pressure, and the bottom number would be the diastolic blood pressure.
Mm-hmm. And what is the quote-unquote perfect blood pressure reading?
So normal blood pressure is a top number equal to or less than 120, and a bottom number less than or equal to 80.
Okay.
And that is normal.
Okay.
Yeah.
And what about fluctuations? I know when I go visit my doctor, sometimes it'll be a little high, sometimes it'll be super low, and I'll be so proud of myself. But do the fluctuations matter?
Yeah, it's a really good question because we all have fluctuations in our blood pressure. I walked over here from the office. I was running a little bit late, and I had to move a little more quickly. So my blood pressure is going to be higher when I arrive here than when I first wake up in the morning relaxed. So all throughout the day, our blood pressure is going up and down, and that is normal and expected. When we talk about blood pressure goals, there's a very specific and standard way that blood pressure should be measured. So fluctuations that happen during the day, we try to kind of take those out of the equation when we're doing the measurements in the office. And I don't want anyone to be worried that when they're exercising or getting really excited that their blood pressure goes up. That's normal. That means you're human and alive. In the guidelines and standard correct practice is to check blood pressure in a very routine way. And the way you do it is you have the person you're checking sit in a chair with their feet on the floor, their back supported, their arm at heart level. They should sit quietly for 5 minutes, and then the blood pressure should be checked with an automated blood pressure cuff, and that's the reading. Additionally, there should be no exercise, eating, drinking, or smoking for 30 minutes before you check your blood pressure. So if you came to me as a patient and this was the first time I was meeting you and you've never been told your blood pressure was elevated in the past, and we do it according to those guidelines, and your blood pressure was above goal, then I would say, I'm going to ask you to check it at home, because that reading on that one day is insufficient to diagnose you. So you might have just been, high that day for reasons like running into the appointment, or, maybe you had a little bit of something to eat before you came.
Okay.
Yeah.
So what are some of the causes of high blood pressure, and are some people more prone to it than others?
Yeah. So to answer the second question first, really some people are more prone to it than others. Your family history matters a lot. That being said, there are things that can influence your blood pressure negatively that you can control. The two most common outside influencers that, when corrected for, result in normal blood pressure would be alcohol use and non-restful sleep. Commonly, we talk about patients who have a diagnosis of what's called obstructive sleep apnea, where they awaken in the night unable to breathe and then fall back asleep many times, so they're not getting a restful night's sleep. But we see it in people who have a very disruptive bed partner, an uncomfortable bed, other reasons for not getting restful sleep. So those, if you corrected and had someone have restful sleep or you decrease the alcohol intake, then the blood pressure would normalize.
Okay. And are there other risk factors such as smoking and diet, which we will get into because that's part of the preventive aspect of controlling your blood pressure. But I hate to use this term because it's so scary, but it's also often called a hidden killer because there are so little symptoms. Are there any symptoms that do show up that you can sort of keep an eye out for?
It's a good question. I have had many patients tell me they can feel when their blood pressure is high. They don't feel right. They feel fuzzy or headachy or uncomfortable. So I take that patient experience as very valuable. In the medical literature, really you wouldn't see symptoms of high blood pressure unless you were having systolic numbers or top numbers really flirting with 200. So it is silent for most people. And, I wouldn't start thinking that the headaches you get sometimes at the end of a long day are because of blood pressure. That's not really what the observational studies bear out.
When we talk about high blood pressure, what is it physically that's happening in our arteries? Yeah,
it's really just the pressure of the blood moving through the blood vessels, almost like through a pipe in your house or through a garden hose. And so either there's too much pressure because there's too much kind of blood pushing on the walls, or the walls are not relaxing as they should when the blood is moving through.
And so the high pressure is making your heart work harder.
Exactly. And how does it link to heart disease would be, so two ways. One would be the actual work of the heart, because it's systolic blood pressure is when your heart is pumping blood. How hard does it have to push the blood through the body? If it's really working against a very high pressure, then it's going to have to get bigger and bigger. So the muscle of the heart grows to push the blood through, and it can get so big that it can cause something called heart failure because the muscle just can't get big enough. And that can happen with high blood pressure. Also, just like the sheer force can cause damage to the blood vessels, can cause things like heart attacks or vascular disease in the brain.
So now we can move on to cholesterol. First, can you explain a little bit about cholesterol and what it is? And, I think most of us think we can't have too much of it. That would be bad. Yeah. But we actually need cholesterol.
Sure.
If you could just explain its role.
Yeah, so cholesterol is, let's just call it a fat molecule in our body that's necessary. It's part of the cell walls of the cells of our body. It makes hormones in our body. It's part of a lot of important processes in our body. You're right. We could not live without it. But some types of cholesterol particles have a propensity to create what we call plaques in the blood vessels. And the plaques can cause narrowing and occlusion or cutting off of the blood vessels, and that is a major cause of cardiovascular disease. So we can't live without it, but there's definitely too much of it that can cause problems. There's an interplay between high blood pressure and high cholesterol. So when I talk to my patients, I always talk to them about what we call modifiable risk factors for cardiovascular disease. So there's some things that are non-modifiable, some things we can't change. We can't change our age, right? We can't change our family history. We can't really change our gender. But there are things that we can modify and we can work on either through lifestyle or through medications. And those four things are blood sugar, whether or not you smoke cigarettes, blood cholesterol, and blood pressure. And so somebody who has multiple of those modifiable risk factors that are outside of the goal of where we want them to be, they're going to have a much higher risk of future cardiovascular disease than someone who has just one of those risk factors that's outside of the goal. So they really kind of compound each other and elevate each other.
And you had mentioned age. So is more cholesterol common as you age? It's just inevitable?
Yeah, so having higher cholesterol as you age actually is probably inevitable for women. When we go through menopause, we start to get higher levels of the bad cholesterol or LDL cholesterol, I'm sure. But age is a risk factor for cardiovascular disease, not necessarily for changes in cholesterol. So the older you get, the higher your risk of having a cardiovascular event. The risk of a 20-year-old is very different than the risk of an 80-year-old, and you can't change that.
Right.
It just is.
Right.
Yeah.
And speaking of LDL and HDL, can you explain those a little bit?
Sure. Okay. So there's a lot, actually, of different cholesterol molecules, and I would ask you to bring a lipid specialist to go through all of them, but I can certainly speak about the major ones we talk about. So when you get a standard lipid panel from your primary care doctor, there are 4 things that come up on it. One is the total cholesterol. The other is the triglycerides. And then the 2 we're going to focus on for a second are the LDL, low-density lipoprotein, and HDL, high-density lipoprotein. So LDL is called the bad cholesterol. The reason it's called the bad cholesterol is because those molecules have the propensity to stick to the blood vessel walls and create plaques and create cardiovascular disease. So the more of those molecules that you have, the higher your risk of having those plaques form. HDL is the good cholesterol because not only does it not form plaques, but it helps clear the other cholesterol molecules, the ones that can form plaques, out of your blood vessels. And so it's kind of like a vacuum. So you want more of that. A high HDL is a good thing. A high LDL, not so good. So there's another measurement that we talk about a lot, and it's called the non-HDL, which is just the total cholesterol minus the HDL cholesterol. It's as simple as that. And so that is a measurement of all of the bad particles because you're taking out the good particles from the total. So a primary care doctor will look at your LDL and your non-HDL and think about, are you above target for those? And are you at risk for plaques because of that?
Okay. Interesting. So now we just learned that new guidelines have come out for screening patients. So you could just give us an overview.
Sure. The new guidelines are quite a departure from the old guidelines, and I think that they will be life-saving for people. So the first part of the guidelines, there is a recommendation to check lipids in children. I think the age to start in the general population would be between the ages of 9 and 11, just a one-time screen.
And that's new. We haven't done that for children before.
So now coming back to adult medicine, we start screening at age 19, screen every 5 years. That's part of the new guidelines. And then here's the really new part. So now there are both treatment goals and target goals for the LDL cholesterol. In the guidelines that we had prior, there were what we called statin-eligible groups of adults. And those groups would be started on a statin if you met the criteria for a statin-eligible group, and then you just would be on the statin. And there was no recommendation to check your LDL cholesterol or a goal of where that LDL cholesterol should be. A lot of data and evidence has come up since those guidelines came out showing us the true benefits of really lowering LDL to low levels depending on your risk level and the life-saving benefits of that. So now there's a recommendation to treat low risk, the lowest risk individuals to an LDL less than 100, and then lower than that for higher risk.
And can you give us an idea of the baseline for, and you gave us the idea for a good blood pressure number. What is a good HDL, LDL number set?
So now we do have great guidelines to show us what the LDL should be. Before it was just lower it from what it is. your LDL, you want it to be as close to 100 or lower as possible.
Okay.
So when I see a patient in practice, I will check their cholesterol panel, and I will see what their LDL is. If it is above 100, then I need to think about what is their future risk of having cardiovascular disease. And lucky for me, I don't just have to scratch my head and think about it. There is a risk calculator that's attached to the new guidelines, Prevent Score, that's also new. And so I can use the risk calculator to let me know what the person's 10-year risk of having cardiovascular disease will be. The cutoff should be a Prevent Score of greater than 10% to initiate treatment to get an LDL less than 100. So it's a very clear kind of stepwise way to organize treatment for cholesterol.
And you had mentioned statins. Can you explain a little bit about what statins are, what they do, when they're prescribed?
Sure. Okay. So statins are medications that kind of allow us to not make as much cholesterol. And they are the first-line treatment for hyperlipidemia or high cholesterol. Treatment is initiated depending on your LDL, initial LDL, and your Prevent Score, and your target also based on that. Statin medications are categorized based on their potency. So there's low, moderate, and high potency statins. And so the potency also correlates with how effective they will be at lowering your LDL. So a high potency statin will lower your LDL probably by about 50%. Okay. And maybe moderate, between 30 and 50, and low less than that. The difference between the low potency and the high potency also is kind of the duration that they last in your blood system and the time of day you should take them. But overall, they're very similar medications, all of them.
And when we were talking about statins, what would happen if you just decided to go off it?
Yeah, it's a great question. So I tell my patients when I start them on the statin that we're starting this medication. It's really safe. There are very few side effects, but sometimes people can have these statin-associated muscle symptoms. And if you feel like you're having them, reach out to me. If you are having them and they're very bothersome, stop the statin. Because we want to know if the symptoms go away when you stop the statin. It is safe to stop a statin. When we think about statin therapy, I do think of it as a chronic medication, as a lifelong med. But taking a step back from that, I also think of it almost as like putting money in a bank and compounding interest, but for a statin it would be compounding benefit. So the longer you're on it, the more benefit you're accruing from it. And so you're kind of building up benefit using the statin over many, many years. And I think that's one of the major reasons why the guidelines changed to screening and treating at lower ages, is that they saw that if you could keep the LDL low in young, healthy people, it's like starting your bank account.
Get a head start,
right?
Yeah.
Early, then you can accrue that benefit over time, and it pays off.
Okay. And now we want to talk about prevention.
Yes. So let's start with high blood pressure. So if you want to do, let's say, what we call lifestyle changes to decrease your blood pressure, first things first, get moving. So movement is going to help dramatically. The recommendation is to do 150 minutes.
Which sounds so daunting.
Yeah, which sounds so daunting. It's just 30 minutes, 5 days a week. But when you say
you break it up,
yeah. Of kind of low to moderate intensity cardiovascular movement. I talk to my patients about this all the time. I think when we think of movement, we think of a lot of sweat, really out of breath.
Going to the gym. Yeah.
Really going to have to flop down on the ground afterwards and breathe heavily. But you can also do something called level 2 movement, which is incredibly effective for blood pressure and longevity. So if we broke up movement in levels, level 0 is not moving, what we're doing right now. Level 1 is what you do in your normal day, where you're walking to work, getting your groceries, doing your laundry. That's level 1 movement, and it counts. It's better than not moving, but it's not exercising. So when patients say, well, I do walk from the subway to work, I say, continue doing that and do some level 2. So level 2 movement would be a movement where you're moving a little faster than you do in your day-to-day. But if you and I were doing it together, we could probably have a little bit of a conversation. And if I were doing it alone, I could sustain that pace for up to an hour. So you're not pushing yourself to the max. You're just pushing yourself to get your heart rate a little bit up. Nothing crazy. For the diet, we do know that a Mediterranean healthy diet in that way, a balanced whole food, whole grain, not processed food, not high in sugar and an excess salt diet will be much better for your blood pressure than the normal American diet of processed foods and fried foods and salty foods. So that would help too. Abstaining from alcohol, that would be the official recommendation. Now, in real world practice in my office, I would take someone's history, talk to them about their alcohol use, and then cutting down even is going to help. So you want to start from where the person's at and come down, and then restful sleep. So being able to sleep through the night and waking up refreshed. Those things will definitely help your blood pressure. Also, weight management, not losing tons of weight, but losing, 5 or so pounds can really help blood pressure. So for hyperlipidemia, high cholesterol, so prevention would be all the things I just said. Certainly helpful to have that movement, that healthy diet, abstaining from alcohol. That will help prevent high cholesterol. In terms of treatment, 2 major things would be weight management, and then there are some dietary changes. It doesn't help everyone because genes are very powerful in many people, but eating a diet that's low in saturated fats will help. And then also a diet low in simple carbohydrates can also help. So some of that change in diet and weight management in that way can help decrease your LDL cholesterol and get you off of statins.
Okay. Well, this has been very helpful and informative. So we just want to make sure that our members know to have their cholesterol checked, have their blood pressure checked when they go to their PCP. Is there anything you would like to leave with our members about the combination or either one?
Yeah, I think I just would want to emphasize that idea of the modifiable risk factors and the idea that they all kind of work together. And so when I meet with patients, I always talk kind of in this holistic way. And so the best thing you can do is focus on your nutrition, on your movement, on your sleep, and on your stress. And those are in your control. And obviously, if you need assistance, talk to your primary care doctor.
That's great. So we love that the PCP is your first stop, really.
Yeah, first and perhaps final. Yes.
Okay. Well, thank you so much for joining us. We really appreciate it.
Yeah, thank you so much for having me. This was a lot of fun.
Tune in later this month to our May keynote to hear Dr. Gover share information about alternatives to statin medications and why they may be a better option for some people trying to lower their cholesterol. For more information on what you heard today, please check our show notes. And remember, subscribe to Health is the Key wherever you get your podcasts. This podcast and its content are presented solely for general informational and entertainment purposes. The information and opinions provided on this podcast are not intended as legal or medical advice and do not constitute or serve as a substitute for professional medical or psychological treatment, diagnosis, therapy, or other types of professional intervention.